How do you manage the airway in the trauma patient? How do you recognize a difficult airway? What are some of the maneuvers that you can do to help clear the airway? All right, today we're going to be talking about maybe one of the most important topics, and that's the start of the primary survey in trauma, the airway. Let's get to it. Welcome back to Citizen Surgeon. My name is Dr. Eric Pearson. I'm a pediatric surgeon, and I've created Citizen Surgeon as a platform to help scale surgical education and a resource to help you get more comfortable on the wards, in the ICU, in the operating room, and of course, help you crush your exams. So if you haven't had a chance to subscribe, click the subscribe button, turn on the notifications, and then you can be aware when the next video comes out. Also, check out citizensurgeon.com. I have a great newsletter that I'm sending out called the Saturday Six things that have kind of inspired me or changed the way that I've thought that week. And so I'd love to share that with you. Also, I'm building a community on the Circle platform. You can find that at Citizen Surgeon. Great way for those of us in this community who want to get together, scale education, connect with each other, because it's not just about me, it's about each other, all right? So definitely check that out. I'm really excited about it. But today we're going to be talking about airway, and specifically the airway in trauma, to continue the trauma video series. Let's do it. So why do we need to know about the airway? Well, the airway is number one. There's a reason that this comes at the beginning of the primary survey in trauma. If you don't have a clear, stabilized, or definitive airway, your patient is going to go downhill really quick. So the purpose of today is how to get comfortable with the airway, how to know when an airway is clear, how to predict a difficult airway, and then, of course, some airway management techniques. So when we have problems with the airway, it's usually either a failure to assess, a failure to recognize, or a failure to act. When we have a failure to assess an airway problem, it's often a failure to understand the patient, or a failure to understand the airway anatomy, perhaps understanding that the airway is shorter, is much more anterior in a child, or of course, to misunderstand the situation. When we have a failure to recognize would be not knowing that you need to have a definitive airway, perhaps not recognizing that the GCS is 6 and the patient can't have a safe airway on their own. It's also being able to recognize when you're further down in the primary survey that an airway has become displaced. Maybe you have a definitive airway that became displaced and you need to correct that. Or recognizing that the airway that you thought was a definitive airway is actually not placed in the correct position. And then not knowing your plan B. Whenever I do a surgery or when I'm taking care of a trauma patient, I have plan A, but I want to have plan B and C in my pocket so that I know where I'm going to pivot if something goes wrong or if something doesn't follow the course that I expect. When we have a failure to act, that's not having the skill set to place a correct airway. I always feel that it's the most experienced person in the room that should be getting a definitive airway in a trauma patient. It's not knowing the skill set to do a surgical airway if indeed that's indicated, and obviously not being able to adequately secure an airway. So when we start out by evaluating the airway, we start out by asking, what's your name? If the patient can clearly say, my name is Eric Pearson, then that airway is clear, at least clear for now. However, perhaps your patient was thrown from an automobile like this one and is found down at the scene, and his GCS is less than 8 and he can't maintain a safe airway. Or perhaps you have this patient who has suffered inhalation injury and severe facial burns after a house fire. That airway is going to be a little bit different than the patient that's giving you a clear, my name is Eric Pearson, on the question of what's your name. The reason that we need to recognize an unstable airway is that we have to know whether our patient can maintain oxygen and ventilation without an additional intervention. If they can't, for whatever reason, maybe they have airway obstruction, Maybe they have a reduced GCS. They have these things and you do not have a stable airway, then you need a definitive airway. So what is a definitive airway? A definitive airway is defined as a tube in the trachea with the cuff inflated below the vocal cords that is adequately secured and delivering oxygen and removing CO2 gas. That's the definition of a definitive airway. I'm going to show you a bunch of airways that are not definitive airways. For example, an oropharyngeal airway or a laryngeal mask airway. These are examples of not definitive airways. However, they can certainly help you deliver oxygen and ventilation. They're just not a definitive airway. So when we think about the airway in the trauma patient, there are some problems I want you to think about. Take this patient here with a lot of bruising in the neck and the submandibular area. What are you worried about? Or when would you be worried about having trauma to the larynx? I remember I had a patient when I was a resident who had dropped a barbell across their larynx, and on transport we were notified that the patient had massive subcutaneous air. Now that patient on delivery, you know and you need to be ready that you most likely have a laryngeal fracture, and how are you going to handle that patient on arrival? So what are the keys to knowing somebody may have laryngeal trauma? Number one is hoarseness. Number two would be subcutaneous emphysema. Or number three would be a palpable fracture when you're doing your neck examination. Another problem to think about is maxillofacial trauma. So in motor vehicle accidents where you have head injuries that can be on the windshield or on the steering wheel, or in auto pedestrian injuries where you have a head hitting the asphalt or the concrete, you have pretty severe maxillofacial trauma. What are the things that are going to cause problem? Well, you're going to have bleeding. That blood can obstruct the airway. You're going to have swelling. You're going to have a lot of secretions. You might have dislodged teeth. And of course, you have loss of the anatomical support of that upper airway. When we think of these two problems, laryngeal trauma or maxillofacial trauma, these two patients, or these patient examples, are at a higher risk of airway obstruction. So what are some of the signs of airway obstruction? So you have a patient that's scared. They're agitated. Imagine how you would be if you couldn't breathe. As the airway obstruction gets worse, they might be obtunded or unconscious. They could be cyanotic. Obviously, they could be hypoxic. And of course, if they have maxillofacial trauma or laryngeal trauma, they could have stridor, hoarseness, or gurgling. If they have these things, then you need to be worried that you have an impending airway obstruction and you need a definitive airway or a tube in the trachea with the cuff inflated below the cords. So in addition to oxygenation, we have to ask ourselves, is there adequate ventilation? Ventilation is the exchange of air. And so what are some of the things that can cause poor ventilation? So the first thing is airway obstruction. So if your airway is obstructed, you're not going to ventilate. You're not exchanging air. Two is if you have acute brain injury or CNS injury or CNS depression. It could be from drugs and alcohol or drugs that you've given the patient. If they have CNS depression, they're not going to have adequate ventilation. In addition, they may have altered breathing mechanics. So if they have multiple rib fractures or a flailed chest or an open pneumothorax, they're not going to move the lungs in order to exchange air, and you're going to have to fix that problem. So how do we make sure there's adequate ventilation? So first is to look at the chest. I'll look at the chest to make sure there's not an obvious deformity. I'll look for symmetrical movement. If there's a large or the right chest seems bigger or more protruded than the left chest, then perhaps they have a pneumothorax that's developing on that side. Is there paradoxical movement of a part of the chest? Do they have a flail chest segment? Is there bruising around the chest? Do we have to be worried about thoracic trauma leading to poor ventilation? Of course, you also want to listen for breath sounds on the right and left. If they have an endotracheal tube already in place, you want to listen for breath sounds and make sure that they haven't been right mainstem intubated. You also want pulse oximetry, and you want a good waveform so you can know what the blood oxygen saturations are. And of course, capnography, or evaluating the end tidal CO2 or carbon dioxide, give you an idea of how your ability to ventilate is. Also, knowing your end tidal CO2 or your capnography will allow you to keep that number within particular ranges when you have a patient with a head injury We'll talk about that in the head trauma series. So let's get into airway management. So the first thing about airway management is being prepared. Now, I'm going to give you a list, or at least a few things that you're going to want to need. And these are some of those things in the trauma assessment video, initial assessment management of the trauma video. I talked about that trauma timeout when you're confirming that the airway physician has all of their equipment. So here's some equipment that you need as the airway physician to make sure you can get a definitive airway in a very safe way. You want to make sure that you have oxygen, that you have suction available to suck that blood and secretions if there's maxillofacial trauma. That you have a working pulse ox device. That you have extraglottic devices or airways like a laryngeal mask airway. You have capnography available. That you have endotracheal tubes of all sizes in order to select the right tube for your patient. That you have a laryngoscope and that you have the right size of laryngoscope and the type of laryngoscope, whether it's a Mac blade or a Miller blade, or perhaps you're using a glide scope that you're comfortable with. Make sure that you have a mask and a bag valve in order to deliver good solid breaths. And actually know that you have the technique in order to do adequate bag valve mask ventilation. You should have drugs needed to not only sedate the patient, but paralyze them if that's needed. And of course, a bougie can help you get a definitive airway safely. It's important that you have this equipment in order to get a definitive airway safely. One thing I always like to talk about is making sure that we have a stable C-spine. So when we're clearing the airway or we're getting a definitive airway, we need to make sure that we're holding midline cervical spine stabilization or have a C-collar in place. Now, a big question comes up is, how do we predict a difficult airway? What are the things that we can assess to let us know that this is going to be a challenging airway? Maybe we need additional equipment. Maybe we need additional expertise. So this paper right here is put out by the American Society of Anesthesiologists, and I'll put a link to it in the show notes or the description below. And this is an excellent review on how to evaluate for a difficult airway. One tool that I think is incredibly useful is the Lemon tool, and I'll have a link to this in the description below. And I think that this is a great reference card for predicting a difficult airway. So let's go through it. So first is L, and that stands for look. So just look at the patient. Do they have a short stubby neck? Do they have loose or dislodged teeth? Do they have maxillofacial trauma or laryngeal trauma? Just open your eyes, look at the patient, and you can say, is this going to be difficult just from the outset? E stands for evaluate 3-3-2. All right, so 3, have the patient open their mouth. Can you fit 3 fingers between their incisors? That's the first 3. Second is the distance between the chin and the hyoid bone. If that's less than 3 fingers, that could be a difficult airway. And 2 is, can you measure 2-finger distance between the floor of the mouth and the thyroid notch? If you don't have distances at or greater than 3-3-2 for the distance between the incisors, the distance between the chin and the hyoid bone, or the distance between the floor of the mouth and the thyroid notch, then that can lead to a difficult airway. So M stands for Mallampati, or the Mallampati score, and I'll take you through each of these. So Mallampati 1 is an easy airway, or should be, or it predicts an easy airway. And this is where you can see the soft palate, you can see the fosses or the arched opening into the airway, you can see the uvula, and you can see the tonsillar pillars. That's a Mallampati 1. When you can only see the soft palate, the uvula, and the fosses, that is a Mallampati 2. Now this still, even though you can't see the tonsillar pillars, this still predicts an easy airway. When we get into the difficult airways, this is Mallampati 3 or 4, and a Mallampati 3 is where you can only see the soft palate and the uvula, and for a Mallampati 4 is where you can only see the hard palate. Now if you see this, that predicts a difficult airway. So Mallampati 1 and 2 predicts an easy airway. Mallampati 3, 4, where in 3 you can only see the soft palate and the uvula, or in 4 you can only see the hard palate, that predicts a difficult airway. O stands for obstruction or obesity. So in obstruction, if you have a large neck hematoma, a foreign body, dislodged teeth in the airway, that predicts a difficult airway. In obesity, they have more difficult airway with extra soft tissue. So N stands for neck mobility. And in trauma patients where they have a cervical collar or midline cervical stabilization, they already have reduced neck mobility because you want to maintain that cervical spine. It's not cleared yet. And so that already gives you one feature of a difficult airway. I want to stress that in the difficult airway, I believe that the most experienced person in the room should be the one getting a definitive airway if indeed that's needed, or at least evaluating the airway to determine whether a definitive airway is indicated. If you need help, you predict a difficult airway, call for help. Get assistance, get the equipment you need. That might be a flexible bronchoscope. That might be a glide scope. That might be a surgeon to do a surgical airway, and we'll talk about that a little bit too. So now I want to go into a few techniques on airway maintenance. So when we're looking at the airway and we want to have a clear airway, we have to think about some things that we can immediately do to assist that exchange of air. So one thing, the most common cause of airway obstruction is actually the tongue. So you want to get the tongue out of the way. In the conscious patient, you might be able to help with the nasopharyngeal airway, and I'll show you that in a little bit. In the unconscious patient, an oropharyngeal airway may be helpful, and I'll show you one of those. But one technique that can be very helpful is a chin lift. So gentle pressure on the forehead with one hand, where you can see the left hand here under the mandible, lifting that forward, bringing that soft tissue out of the airway, and that can help deliver air. Second is the jaw thrust. So the jaw thrust is nice because you push the mandible forward, lift that soft tissue off of the posterior larynx, and that can help you pass air and also maintain cervical midline stabilization. Seen here, I have the nasopharyngeal airway. That can be useful in getting past those soft tissues to deliver air. And of course, this is good in a conscious patient. You don't want to be putting in a nasopharyngeal airway in somebody with midline facial fractures, as you can make the situation worse. But if they don't have midline facial fractures or maxillofacial trauma, you can place a nasopharyngeal airway, and it can be measured from the nares to the lobe of the ear for a correct sizing. The oropharyngeal airway is here, and that's in an unconscious patient without a gag reflex. You put an oropharyngeal airway, that's going to get the tongue out of the way, help you to deliver oxygen and remove CO2. So it's really important for you to know the difference, and I've kind of grinded this home both in the initial assessment video and in this video, what's a definitive airway and what's not. So take a look at these airways. Are these definitive airways? No, they are not. A laryngeal mask airway, while it's deep within the airway, is not a definitive airway. Either is a nasopharyngeal tube or a oropharyngeal device, a combat tube or a multilumen esophageal airway. These are not definitive airways, but they can be extremely helpful, especially in the situation where you can't immediately get a definitive airway. I'll show you a couple of extraglottic airways here. This is a laryngeal mask airway or a intubating laryngeal mask airway, and that can be very helpful. And seen here, we have a king laryngeal tube, and you can see that this has a couple of ports. So we have a distal balloon where the tube actually goes into the esophagus. You inflate the distal balloon to occlude the esophagus. You inflate the proximal balloon, so then you can deliver air and take away CO2 through this side port. And these can be extremely helpful in a difficult trauma situation. So what are the definitive airways? So a definitive airway would be an orotracheal tube with the cuff inflated below the cords, a nasotracheal tube with the cuff inflated below the cords and secured, or a surgical airway with, of course, the cuff inflated. Now, when do you know that you're going to need a definitive airway? So you're going to need a definitive airway if you can't maintain either of these four things. If you can't maintain your airway anatomy, either because of laryngeal fracture, maxillofacial trauma, airway obstruction from bleeding, secretions, you're going to need a definitive airway. If you can't maintain ventilation, you're going to need a definitive airway. If you can't maintain oxygenation, you're going to need a definitive airway. And of course, if you have CNS depression, for instance, a GCS less than 8, where they can't maintain a safe airway, you're going to need a definitive airway. One thing in medicine that's been described over and over again is the importance of communication and checklists. Now, I'm a big fan of Atul Gawande. His book, The Checklist Manifesto, I'll put that in the description below, really documented how important checklists are in medicine, akin to pilots in the cockpit who have checklists and get us safely from one city to another. Physicians following checklists can dramatically improve outcomes, reduce morbidity and mortality. So this paper right here, I'll put a link to it in the description, has really nice checklists to not only getting set up, but what decisions do you have to make and have under your belt before you decide on intubating the patient, and how do you intubate the patient. First is the pre-arrival checklist. So you can see here that all of these items need to be verbalized by the airway physician or the physician responsible for intubation. That includes the oxygen mask and nasal cannula available, oral airways available like an oral pharyngeal airway, suction available, a proper laryngoscope and laryngoscope blade with a light working effectively, endotracheal tubes and stylets available, extra tubes, extra sizes, a bougie so that you can get an airway through the vocal cords if needed, backup devices including like the King laryngeal tube system I demonstrated, or laryngeal mask airways, in addition to instruments for a cricothyrotomy, all of the monitors and video laryngoscope screen that you might need if you're using a glide scope, a bad valve mask with an end-tidal CO2 detector, IV fluid, and of course individuals that are responsible for maintaining that cervical spine mobilization. In addition, that airway plan has been verbalized. Now this is the pre-arrival checklist, and this could be done in the trauma timeout. So when I talk to the airway physician, I want to confirm that we have all of these things available. Now when we move on to getting a definitive airway, this is a pre-induction checklist. This confirms that we've done the pre-arrival checklist, that we have the airway plan, the IV function, that we have all the drugs that we're going to need, and they've been confirmed and drawn up, that we have cervical spine stabilization, that we've pre-oxygenated with a mask at 15 liters, that our patient position is optimized, and that we have our blood pressure cuff on the opposite arm of the IV line and the oximetry probe. And so let's talk about oral tracheal intubation. So if you made the decision that you're going to orotracheally intubate, you've made the decision that you need a definitive airway, here are some things to keep in mind. As we've talked about, you want manual inline cervical spine stabilization. Want to make sure that you have all the equipment, blades, bougie, endotracheal tubes we talked about. Make sure that you have drugs. As far as drugs, you want usually a sedative and a paralytic. A sedative could be etomidate. We dose that at 0.3 mg per kilo. A paralytic you can use in the trauma situation would be succinylcholine. Now you want to be very careful before paralyzing an individual, because once you take away their baseline ability to breathe, then getting that airway is all on you. And you certainly don't want to paralyze somebody unless you have expertise in securing that airway and you have all of the backup and equipment that you need. And if you've predicted that somebody has a difficult airway, in these patients, you may need an awake intubation or an awake fiber optic intubation because the risk is too high to give that paralytic. Now I'll direct you in the description for some really good videos or for some other information on how to do oral tracheal intubation. But one question that comes up is, how do you know you're in the airway? Well, here are a few ways to check out that you're actually in the airway. So I hope you liked that talk on airway in trauma today. We talked about the ability to assess, recognize, and act when it comes to establishing a definitive airway. We talked about how to look for a difficult airway and all of different things you're going to need if you encounter a difficult airway. We talked a little bit about oral tracheal intubation and when you're going to need a definitive airway. And then, of course, we talked about the importance of checklists and communication. So review the video. Definitely check out those links that I have for you in the description. And again, if you haven't had a chance to subscribe or turn on the notifications, do that. Check out citizensurgeon.com. I'll see you in the community or in the comments. Bye-bye.